This recording is for Chapter 19, Mental Health Disorders and Issues of the Older Adult. So let's talk about what exactly is an older adult. In order to understand that, we have to look at what aging is and what the definition of aging is. So this is something that happens every day. It happens in a continuous fashion and it happens slowly over time. Every single day we are aging. So the physical signs that you may see in your patient, graying hair, thinning hair, loss of hair, maybe a newfound patient has presbyopia where they will need reading glasses, and that occurs sometimes at the age of 40, 45 years old, and the patient that never wore glasses before may have to actually use reading glasses. There's a wrinkling of the skin because of the loss of elastin and collagen, also the loss of the subcutaneous layer. So these are all things that go along with aging. We also have the lessening of the density of the bones as we get older, and the bones actually start to lose their density at age 35. So, and it happens very slowly over time. So, when we think about primary aging, this is genetics. This is based on a person's genetics, their chromosomes that they receive from their biological mom, their biological dad. When we think about secondary aging, these are kinds of factors that are influenced by the environment. So things that are outside of the person's genetic code. If you see box 19.1, that talks about chronic medical conditions that are most common in your geriatric patients, patients that are over 65 years old. A lot of those are considered, again, faced by older adults. Examples will be arthritis, visual disturbances, hypertension, peripheral vascular disease, congestive heart failure, urinary dysfunction, Parkinson's disease, hearing loss, stroke, COPD, thyroid disease, and even diabetes mellitus. When we look in our textbook on page 325, we're looking at box 19.2. These are potential changes that older individuals face. And so the changes, when we think about what happens as we get older, of course, there may be changes in our health, changes in the employment status, changes in family, spouse, a loved one, changes in income, changes in friends. There may be cognitive decline, changes in home. There may be a change in their independence. They may not have the independence that they once really enjoyed. They may have a change in roles as they become dependent upon their family and loved ones. And they may not have a sense of purpose as they get older. So we have to look at all of these issues as we are caring for this older patient in a holistic manner. So not only looking at their health, but looking at their environment, their finances, their family structure. And we also have to look at the health concerns that deal with memory, as well as disease, the loss of loved one, grief and loss, and again, change in their independence level. So when we think about ageism, ageism is a prejudice based on age, okay, and that's referring to older age. And it's driven by common misconceptions that deterioration, senility, and mental health issues are part of the normal aging process. So, in short, it is not normal as someone ages for them to become senile. That's not a normal part of the aging process. For them, an elderly person to lose their cognition, that's not a normal part of the aging process. Mental health issues are not necessarily a part of the normal aging process. So we shouldn't just accept it. It should be identified, reported so that individual can get the help that they need. So when we think about, okay, well, what are these issues? How do we know that something is an issue that's not normal that we need to report? Well, impaired cognitive functioning. So it could be minor, misplacing items, forgetting appointments, being absent-minded, but it's problematic, right? If the patient becomes confused, if they're not able to understand what's going on in their daily life, that is a cause for concern. okay? So there's also different types of cognitive issues that or disorders in the older adult. And so they have a noticeable change in their cognition and form of functioning. That's been a huge discussion point in the United States as we look at our president, Joe Biden. There's a lot of people saying that he's cognitively declining. And I will tell you that his performance on that most recent debate against Donald Trump was not something that was saying that he was winning. It really caused us to be concerned. I'm concerned about, of course, the future of the nation, but looking at him as a patient, I would be concerned if he was my patient because he didn't appear to be um, coherent at times. He seemed to forget his train of thought a lot of times, and he had this stare, right? So that's very different from the Joe Biden that we've known previously. So that was a definitely cause for concern. So when we talk about mental disorders in the older adult, there's a noticeable change in their function. Now, it could be due to an underlying medication. And one of the things that Joe Biden came forward and said that he had a cold. He didn't sleep well because of he was traveling, he was jet lagged. So this is quite possibly true, right? When we look at our patients, our geriatric patients, we have to take this all into consideration. What's the normal for this patient? Is this a major change in their cognition? Is there another issue? Is there an underlying medical condition? Maybe it's a new medication. Maybe there's an infection. Maybe there's something that is abnormal that's going on with the patient that's not necessarily cognitive based. So this leads me to discuss delirium. This is a huge NCLEX concept that you're going to have to really master. Delirium versus dementia. So delirium is short term, it is acute. And this develops over a short period of time. It could be due to low blood sugar, low oxygen. It could be due to an infection. So whenever a patient has delirium, they will have a change in their level of consciousness. They may appear confused. The good thing about delirium is once we determine what the cause is, once we resolve that underlying cause, then the patient will return to their normal level of functioning. So if their delirium is caused by a UTI, we start giving them some antibiotics, start fighting that infection, they should come out of that delirious state. If it's due to low blood sugar, then we will give them some meal, right? Give them a meal. The first thing probably is going to be to give them some orange juice as long as it's not contraindicated. And then get them some food, get them some oxygen. Whatever the cause of the delirium is, we have to address that. And the patient should be able to return to their normal level of functioning. Now, dementia is chronic. It is long term. The patient will not return to their former level of functioning. This is irreversible, it's progressive, and you're going to see a lot of NCLEX questions. The patient has dementia, and the family member, the grandchildren, or the children will say, when is grandma coming home? When is she going to be her normal self again, her old self? Unfortunately, she will never be herself again because with dementia, it's irreversible, it's chronic, it's long term. There's loss of memory. First, there's the short term memory, and then the long term memory or the remote memory is fading. Right? So, this patient that has dementia, they not only have a loss of memory, awareness, judgment, they're not able to have reasoning ability, they're not able to carry out their ADLs. And so there are different kinds of dementia, and the textbook really does a great job talking about the different kinds of dementia. Okay, and so that starts in your textbook on page 328 to 329 and 330. It talks about the different kinds of dementia and really all going on, something's going on with the brain. So dementia can be due to Alzheimer's disease. That's the first thing that we're going to look at. So there's neurotic on the brain. And so the cerebral cortex is really affected with a patient that has Alzheimer's disease. Memory impairment is common though in both delirium and dementia. And so we have to again be very clear when we're looking at our patient. Is this patient in delirium? Is it dementia? What is the patient's baseline? What were they like yesterday? What were they like when they were admitted? What were they like when they're at home? It's going to be really important for us to assess using the nursing process when we look at our patient. Dementia due to Alzheimer's, if we see box 19.8, we will see all the signs and symptoms, and there's a lot of signs and symptoms when we think about your patient that has dementia due to Alzheimer's. There's a fancy word that you definitely need to know, and this is on page 32 of your textbook, is confabulation. Confabulation is the individual is making up information, and this is an unconscious thing. They're making up information because they don't remember. And it's not that they're lying, it's that they're making up this information. They're kind of filling in the gaps. Okay, so that's an important word to be able to identify. So with this patient with Alzheimer's, their short-term memory fails, they have impaired judgment. And on page 331 of your textbook, this is a great figure, 19.2. It's the 5 A's of Alzheimer's disease. This is really important. You need to know these terms: anomia, agnosia, apraxia, amnesia, and aphasia. So when your patient has Alzheimer's disease, we need to understand that they're not able to care for themselves. They may have catastrophic reactions, which are overreactions where they can become violent, irritable, restless. They may also suffer from sundowning syndrome. Sundowning syndrome is during the hours of late night and early morning, they become increasingly confused, agitated, not able to sleep. So important things. So let's just talk about these terms. I just want to make sure that you understand anomia. So this is the inability to find the right word. In class, we're going to be looking at the mini mental status exam. And one of the things that we do is we hold up a pencil and we say, what is this? Now, if your patient says it's something you write with, that could be a bit of a red flag instead of saying it's a pencil. Now, sure, it is something that you write with, but they may have forgotten the word pencil. So when we do that mini mental status exam, that's one of the things that we look at. And again, that's anomia, inability to find the right word. Agnosia is, I'm sorry, inability to identify an object. And so what I just described with the pencil, that's actually agnosia. Anomia is inability to find the right word. And so an example of that would be, oh, I saw the whatchamacallit, right? And they could be referring to a box or a dress or something. And they may use the term whatchamacallit. So anomia is not finding the right word. Agnosia is the inability to identify an object. And that's the example that I gave with the pencil. Okay, apraxia, this is the inability to carry out purposeful movements and actions. So a lot of times you'll see your patients that have Alzheimer's, dementia, they're rigid in their movements. They may be stiff in their movements, or they may pace around in circles. Okay, so that's apraxia. Amnesia, so the loss of recent memory first, and then the inability to recall remote memory. Okay, and so there's a movie, you may have seen it, it's an older movie. It's The Notebook. That is a really touching movie that is a husband and wife, and the woman, the wife has dementia, and the husband visits her every day and tries to have, build a relationship with her again. And occasionally she'll have these moments of lucidity where she remembers him, right? And again, it's progressive. So it starts with a short-term memory, and it's really hurtful because family members will say, I'm your child. How could you not remember me? They're not doing it on purpose. The patient's not doing it on purpose. This just comes with the condition, unfortunately. All right, so we talked about anemia, agnosia, apraxia, amnesia, and then lastly is aphasia, of the 5 A's of Alzheimer's. Aphasia is the inability to give meaning to spoken word or speak in a meaningful way. Sometimes it will be referred to as a word salad, a word salad. So pretty important terms for you to understand. All right, so dementia can also be due to vascular disorder. When we think vascular, hopefully you remember this from med-surg, you should be thinking of your vessels, your arteries, your veins, okay? And so if a patient has vascular disorder, like a stroke, a cerebral vascular accident, there's some kind of damage to the brain. Now, a person can have more than one kind of dementia, okay? Vascular dementia tends to be more common in men than in women. So these patients that have vascular disorders like stroke, you're going to see other neurological symptoms like hemiplegia, so paralyzed on one side, the left side or the right side. And remember from med-surg that the right side of the brain controls the left side of the body. So if your patient is suffering from a right brain stroke, the left side of the body is going to be affected and vice versa. The patient may also have abnormal reflexes, gait disturbances. They may also have uncontrollable emotional responses. They may have cognitive deficits that are due to the damage in the brain. So there's also dementia due to Lewy body disease. And this is really unfortunate because there are protein deposits, which are called Lewy bodies, that develop throughout the brain's nerves cells. So sleeping is, and I'm going to do a quick kind of sidebar for a second. Sleeping is really important because as we sleep, and I tell my daughter this all the time, this is where you grow. So for children, that's important, but also as we are sleeping, our brain actually has a chance to clean itself up. So all of those metabolic waste products that are produced throughout the day are cleaned up as we are sleeping. So there's been a lot of studies that show if people don't get enough sleep, they increase the risk of having these waste particles not being cleaned out well in their brain. So that's really, really important. So when we have patients that have this dementia due to Lewy body disease, they have these Lewy bodies, these abnormal protein deposits throughout their brain. And so what the patient may experience is visual hallucinations. They may have paranoia, thinking, excuse me, people may be out to get them. They may suffer from delusional thinking. And when you think about a patient that has delusional thinking is a patient that has a firm, fixed belief. So with delusional thinking, they have a firm, fixed belief that is false. So you can't argue, you can't reason with this patient because they believe what they believe and no rational, logical explanation through to them. Okay, again, this is dementia due to Lewy body disease. The patient may have Parkinson-like symptoms. When we think about someone that has Parkinson's, they have slow, rigid movements. This is called cogwheel rigidity. They may have a shuffling gait, a stoop posture. Their face is going to be like a mask, so they're not going to be able to show any emotions on their face. Okay, so we call that mask-like faces, right? So again, this is dementia due to Lewy body disease. Okay, so it's important to tell the difference between depression and dementia. So in your textbook, in box 1911, it gives you a lot of information about, um, let's see, 1911 is resources for information on dementia. And on page 334 in your textbook, box 1910, It gives signs and symptoms of dementia due to your Lewy body disease. So please make sure you take a look at that. And then on page 334, it talks about depression. Okay, now, although depression is not categorized as a cognitive disorder, depression is a mood disorder and it can occur in any age group. Depression also accompanies early stages of dementia, particularly in Alzheimer's disease. In class, we're probably going to be talking about the Hamilton Depression Scale. We use that with our geriatric patients to ascertain whether or not they are suffering from depression. And we will also perform the mini mental status exam as well. So if an individual suffers from depression due to Alzheimer's disease, the individual still has the mental ability to understand that something is happening. The memory lapses are occurring and they're unable to do things that they previously were able to easily accomplish. Okay. So this is very disturbing for someone, okay, because they're like, I can't do what I used to do. And this can lead to depression. Okay. So that's important to be able to recognize that in your patients. Again, if a patient, even if it's not a mental health issue, if a patient has a loss of independence, a loss of function, loss of being able to do something that they once loved, there's going to be some feelings of grief, of loss. So we have to pay close attention to that. Sometimes um, dementia may be misdiagnosed because there may be other things going on with the patient. So we have to look at the patient holistically. We have to look at any changes in their appetite, their sleep, if they have loss of energy, initiative. Now, how do we treat these neurocognitive disorders? It's tough because there's not really a cure for any of these conditions. So we have to treat the symptoms to primarily keep the patient safe. That is going to be our number one thing when we think about mental health, when we think about our patients that have these mental illnesses, keeping them safe is number one. Okay, so we have no cure for these conditions that we're talking about now, the dementia, the Alzheimer's, the Lewy body dementia, cognitive decline. There is no cure. We can't restore the patient back to their original state. So we have to control the symptoms, try to control the behaviors, and we can slow the progression of their condition, but we can't stop it from moving forward. So typical medication that will be given to your patients that have neurocognitive disorders, and neurocognitive disorders is inclusive of all the different kinds of issues that we're talking about, the Alzheimer's disease, dementia, Lewy body dementia. So one of the typical medications is antipsychotics, okay, and as well as antidepressants. We may also have our patient attend support groups, and that's something that you're going to see a reoccurring theme with your mental health patients, that we use a multifaceted approach. We're using medication, and the medication takes a couple weeks to kick in. It's not like Tylenol where it breaks the fever in an hour. Antipsychotic medications, mental health medications take at least 2 to 3 weeks to get to a therapeutic level. And in addition to medication, we're going to have individual therapy or group therapy, some kind of psychotherapy to help the patient. So it's a multifaceted approach. Okay, so always remember, we're using the nursing process. That is ADPI, assessment. What does this patient look like? We have to get a good history. And sometimes the patient may not be able to give you that history, so you're going to have to talk to the family member or the loved one or the friend that can give you credible information. We're going to have to understand, what are the medications they've been taking? Are there any new medications? Are there any medications that may put them at risk for toxicity? With your geriatric patient, we also have to think about, is there an issue with polypharmacy? Are some of the medications they're taking contradicting or contraindicated with other medications? So we have to keep all of this in mind when we are assessing our geriatric patient. Okay, we want to get that information and think critically about it. Okay, and so when we think about D, we think about the nursing diagnosis, right? That's what the D stands for, the plan, and any interventions. What can we do to help the patient continue with their ADLs? What kind of things can we put in place to help that patient? Okay, and then after we put these interventions in place, we have to evaluate, was it successful? Did take care of the underlying issue, or is there another issue that we didn't identify? So that was for delirium. Delirium is acute, sudden onset. As long as the underlying cause is resolved, the patient will be able to be restored to their original level of functioning. When we think about dementia, remember, this is a progressive, irreversible kinds of condition. And when we're assessing this patient, we have to think about that. Okay, the family's going to tell us, okay, are they able to carry out their ADLs, their activities? And then again, the diagnoses, the planning, the interventions, and then evaluation, okay, for your dementia patient. All right, so here's a question. Which of the following disorders is characterized by a disturbance of consciousness and a change in cognition that develops over a short time? Is it delirium, amnesic disorder, Alzheimer dementia, or vascular dementia? Take a moment to pause the video and think it through. It is delirium. Hopefully you got this one, right? And so the rationale is that there's many different causes for delirium in older adults. And we mentioned some of the causes: low oxygenation, low blood sugar. It could be medication. It could be infection, sepsis, right? So there's many different causes, but a person with delirium presents with a disturbance in the level of awareness and cognitive functioning. So if Mrs. Smith was totally with it, and then, 2 days later, you come in and you check on her and she is confused, she's restless. Okay, this patient is experiencing delirium. And I will tell you, for you, most of the time, it's because of an infection. Okay? All right, here's question number 2. Sundowning syndrome is the inability to find the right words, impairment in the significance or meaning of language, filling in the gaps with fictitious statements, or peak period of agitation, acting out behavior. Take a moment to pause the video so you can get the answer. All right, it is D. This is the peak period of agitation and acting out behavior. And so sundowning syndrome is associated with Alzheimer's. There's a cute little visual aid that shows the patient that the sun is setting and they start turning into a werewolf. I will tell you that it's really true. I had a patient, she was about 90 years old. She was pleasantly confused during the daytime. She was just so sweet as can be. And at night, she became mean. She would slap you, she would pinch you. So it is a real thing. Sundowning syndrome is usually associated with Alzheimer's. And so these behaviors are because of fear, because of confusion. They don't understand what's going on. They're not able to process the stimuli. They don't know why you're coming up to them and offering them medication, right? So they become combative sometimes. And it's very disturbing to see. All right. Question 3. This is our last question. Whether the following statement is true or false. A client with either depression or dementia will attempt to answer questions, but the answer might not make sense. Is this true or false? Take a moment to pause the video. This is false. One of the distinguishing factors between dementia and depression is that a depressed will usually answer questions with "I don't know." whereas a demented person will attempt. And again, remember, making up those facts unconsciously is confabulation. That is a word that you must know, confabulation. Depressed patient will say, I don't know, right? But the demented person will attempt to answer. Well, this is a conclusion of the discussion of chapter 19. And remember, always think like a nurse.